So our next speaker is Dr. Ann Reynolds, developmental pediatrician. And I just wanted to send a few reminders before we start with Dr. Reynolds to check the app. And if you don't mind, just put in your session evaluations. They're by session and just takes a minute. Also, for any of you that have consented into the blood draw or the biospecimens, if you did not have a slot that was available for you on the sign up, that's okay. They're taking walk-ins and it's right off the lobby. So as long as there's nobody there and you've consented, you can feel free and do that today if you wanted to. So I just wanted to mention that. And without further ado, Dr. Reynolds, thank you so much.
This is fine. So hello, I'm really very pleased to be here today. I was asked to talk about what you can expect when you have a developmental PEDS evaluation. And I thought I would give you an overview too of how we think about different things that you may be struggling with, like behavior and sleep, understanding that you will have more in-depth talks about these things at different times during the conference. One of the things we do is we make diagnoses of developmental conditions, but we also try to identify any co-occurring conditions that might be impacting behavior development and just most importantly, quality of life. So when we do diagnostic testing, we usually look at cognitive and sorry, my glasses were not working with my progressive lens yeah. So we would do cognitive or developmental testing, adaptive testing, and then potentially social communication testing. And depending on where your clinic is, you may or may not also have speech, OT, or PT, or a learning evaluation. So when we do the testing, these are standardized measures that are either developmental tests if you're 3 or younger, or cognitive tests if you're older. But we may have to do the testing in a non-standard way because maybe your child is really upset or distressed by being in a new place. They didn't sleep well the night before. They may have motor issues that interfere with testing, or they may be nonverbal. So often it can be frustrating for families when we can't give you a definitive diagnosis or developmental level. But what we're doing is just trying to get a good estimate for deciding what therapies might be needed. But what we also do is look at adaptive function. And this is something that you may be doing periodically throughout your child's life, looking at how do they do day to day. So not just how they do in a strange room with 2 to 4 adults to 1 child, no distractors, but how they are actually doing in the real world. And it's very important when you're either filling out this questionnaire or answering questions to think about, how does my child do typically, not what can they do in the most ideal setting. And because it's important to understand that to provide the appropriate resources and supports. But it's always important for us to get information about how your child does at home and at school. Another evaluation that we do is an evaluation for autism, and that can include, that usually includes a caregiver interview, or it should include one, along with questionnaires or and often information from therapists and teachers, especially during COVID. They're the ones who get to see your child with other kids. Although now that social distancing isn't as important, we'll hopefully be able to, parents will be able to see their kids on the playground or in school. And then we do autism specific testing. And so when we do, this is also a standardized test. We're looking at behaviors, pressing your child for social interaction, waiting to let them request, because I think sometimes as adults, we kind of scaffold and structure our kids, and we know the child likes bubbles, but it's important in this test to see how they'll request it if you just don't keep blowing the bubbles. But for this test to be what we call reliable, your child needs to have a developmental level of at least 14 to 16 months. They need to be mobile because we want to see which toys they might choose. And they have to have adequate vision and hearing. And so I think what happens a lot of times is, if a child isn't mobile, or a child, is not yet developmentally at 16 months, it can be difficult to interpret the results. And so sometimes, again, you run into the fact that when people are talking to you about the results of the testing, they may have to qualify their, or talk about, we're not real sure. These are the symptoms we're seeing, and these are the, these are the ones that are associated with autism, and these are the ones that aren't. And so I think that it's particularly difficult in children who have genetic conditions. And I think some of that has to do with, let's see. Yeah, sorry. Some of that has to do with the fact that the child may not present exactly as someone who has, classic autism. And this is particularly true for children with 15 Duke 15q, who may have more, they may show their, or demonstrate their facial expressions to people more frequently than a child who has classic autism, or they may also have a better social smile. So if someone smiles at them, they smile back, or they initiate smiling. So sometimes we struggle with a diagnosis in children who may not present in that classic way. I would say that what we usually do then is have a conversation with the family and say, it's not clear cut. We feel like though your child has enough of the symptoms that this diagnosis would be helpful, because it provides a common language around, what kind of therapies do you need, what kind of interventions you may need. And it helps schools and therapists and the insurance company to have a common language to describe the things that your child needs. We also look at medical and psychiatric conditions. 50 to 80% of kids with developmental delays also have sleep. And these are each one. 50 to 80% have sleep problems, 50 to 80% have feeding issues, and 50 to 80% or even more have GI issues. And so these are things that can impact behavior. And also high pain tolerance makes it hard to know. what's going on. We also like to make sure kids are getting to dental visits, even if it's just for a quick peek, or using a child life specialist or desensitization to help them with those visits. Also, children with developmental issues could also have a co-occurring anxiety or ADHD. And so it's important to think about that as well. And one of the things that I feel is super important is thinking about the complexity of these issues in a child with developmental delays, because there's so many things that could be going on. And this is someone else is talking about sleep, but when you think about sleep, there's so many things that could impact it. It's, there are behaviors like difficulty with transitions, or, my child won't sit and let me read a story to them at bedtime. So it's really hard to calm down. Biological differences in melatonin production, GABA and glutamate, things like that can have an impact on your child's sleep. But also it could be that your child's constipated or has reflux, and that's causing pain because every 90 minutes you cycle through light sleep. And if you're having pain or discomfort, it can wake you up. And then ADHD and anxiety can also impact sleep. So I think with everything in children who have developmental issues, we have to think about all the different things that could have an impact. So I'm going to kind of shift gears to behavior. So behavior is the tip of the iceberg. So tantrums, aggression, this is the outcome of all these things that are below the surface that might be contributing to their sleep issues. Are they tired? Are there too many sensory issues? Are they frustrated because they can't communicate, or the expectations of that setting are too high for them? Do they have pain or discomfort? Is this a change in routine or environment that's really throwing them off? And so I think that it's really important to think of all of these things when you're looking at behavior in a child with developmental issues. And so we talk about the ABCs of behavior. So that's antecedent, behavior, consequence. So what's the behavior look like? What are the triggers? And then what are the consequences of the behavior, or things that could reinforce the behavior? And when we're looking at behavior, especially in the school setting, what you would ask for is something called a functional behavioral assessment. And that's where you really look at these triggers. How often is the child having the behavior? How severe is it? You also want to look at, what does the behavior get them? Oh, if I have a tantrum, I get to leave the classroom and I don't have to do this task, or I get to leave the classroom and my mom comes to pick me up, or is it for attention? A lot of times kids will what looks like hitting is really trying to pat you to get your attention, but they can't grade the movement adequately. And so usually adults can figure that out, but siblings can't, and other children may feel like they're being hit. So looking at, is it for attention or is it for communication? Which I think often behavior is basically a way to communicate when it's hard for you to communicate in other ways. So, you always want to try to address these issues. And, if you can't address the triggers, then how can we help the child to cope with those different triggers? So, visiting a new place, you might take pictures or go there ahead of time to see it. Warnings, timers, visual timers, picture schedules, those kind of things can be helpful for preparing a child as well. And then coping strategies like deep breaths or that kind of thing when something is distressing for them. So one of the things I think a lot of families have a lot of questions about, like ABA or behavioral therapies, and there are all kind of different types. And it's important to recognize that ABA just means that you're looking at behavior, you're trying something, you're looking at how you make improvements. But it doesn't necessarily mean that you're sitting at a table with a reward, and you do a task. So you really want it to be developmentally appropriate. There should be a parent training component so that everybody's working on the same thing at the same time. You want a natural environment if possible. And then you also have to think of it, it's not just to decrease a negative behavior, but it's also to increase positive behaviors, so that, or adaptive things that you would like the child to learn to do. And then it's important that any therapist respects your family culture, what's important to you and your family, not just what's important to them. And then sometimes we use medication to help with behavior as well. I think that anytime you have a comorbid mental health condition, it can be very difficult to make that diagnosis, but also the intervention should always try behavioral type strategies first. And then sometimes medication can obviously be helpful. The treatment of choice is cognitive behavioral therapy first, in children with autism spectrum disorders. So cognitive behavioral therapy uses cognitive skills to, to work through something. Is this a big deal or a little deal that my friend sat in the chair I usually sit in? Or cognitive distortions. My friend didn't want to play with me today. It doesn't mean they hate me. It means they wanted to do something different, so those are important things. But you can also, cognitive behavioral therapy is really works best in children who are over 7 or have a IQ above 70. But you can adjust it for children who don't have as many skills, and you just put more emphasis on the behavior part, use of visuals, that kind of thing. And then when we're thinking about treatment with medication, this is just a nice example of how do you treat ADHD in a child with autism? And it goes through kind of a pathway, well, sleep can make you look like you have ADHD. Let's make sure we treat that first. Or is it ADHD or is it anxiety? So if you are looking, if you're moving around all the time, is it because you're kind of in the flight mode or fight or flight? Are you easily distracted or hypervigilant and paying attention to everything around you? Because it might be a negative. And then is inattention difficulty paying attention? Or are you just too busy paying attention to your worries? And then also obviously thinking about preferred versus non-preferred and the setting, and then making sure you've optimized behavioral supports. Usually if you're going to use a medication, and I think someone's going to be talking more about this later, you just start with very low doses and go slow. And instead of starting with a stimulant, you might start with an alpha agonist like clonidine or guanfacine. This is a really nice handout for families that helps them to make decisions about whether they want to use a medication. And then I don't know when I don't know how much time I have. Okay. Well, anyway, yeah, sorry. Okay, so this is just based on a actual patient, but changed quite a bit. But it was a patient. So this little boy comes in, and his mom's concerned about depression. They just moved. He's in a new school. He has his own bedroom now, which is new. It's actually a really good school where he has more one-to-one, but he's really had this new onset of being really irritable and having trouble sleeping, which could actually be depression. But when you ask more questions, you find out that, or so you think about, well, is this change in routine? We moved, anxiety about being in his own room. But when you ask more questions, it turns out that his mom isn't working outside the home anymore, so she had more time, so she thought she'd potty train him. And he did really well with training for urine, but he was not pooping in that potty. And so he started withholding, and then he was really uncomfortable. And so that was waking him up at night. And for this particular child, working on the constipation helped their sleep, and helping their sleep helped their irritability, and things got better. But if you didn't ask enough questions, you could really miss that and put him on a medicine for depression when it really wasn't indicated. Does anybody have any questions for me?
Okay. Thank you so much, Dr. Reynolds. We have a few questions on the app. And if any of you wanted to raise your hand, I do have a mic and I'll try to run over to you. So the first question is somebody who's here actually. When is it appropriate to seek out a developmental pediatrician?
Well, it could be at any time. I think that if you're looking for a diagnosis, but also just if you're feeling like, we're transitioning to kindergarten and we're not sure the things that we need to be thinking about, or we're moving into middle school and puberty and we're not sure, we have a lot of questions. So I think it really is at any point. And it's also good once you see one to kind of maybe see them relatively regularly, because sometimes things crop up, like, sleep gets worse, or, you start potty training and things get out of hand.
Thank you. When establishing the diagnosis for developmental delay and establishing developmental age, is there any way of knowing if the age gap between the delay and the real age will remain consistent? And is there any way of knowing if and when the child will stop progressing developmentally?
That's a great question. So typically that we think of development like a growth chart, so you're getting, you're always getting bigger and bigger, and then you kind of plateau off. What I would say is that if if at 6 months you have a 2-month gap, it can get bigger with time, because your progress will be at a slower pace. I wish I had a good picture for that. But what I would also say is, I don't think that there's a time when your child isn't going to grow and learn things. I mean, I'm still learning things, hopefully, and also it's important to think about, like, 18, even though you may stop growing at 18, your brain is still developing until about 27. And I have seen kids make lots of developmental progress, like at 9 or 15. It just depends on the child and when things kind of click in. So I would say that your brain's still changing until about 27, but there's always an opportunity to learn new things.
What does, sorry about that, behavioral therapy best work for example, talking, independence, or a certain age?
I think it depends on the child. So we think of behavioral therapy as, to try to decrease things like aggression, self-injury, that kind of thing. But it also can be very helpful for learning other skills. Sometimes I have patients who, the behavioral therapy is to help them get out into the community and tolerate going to the pool or the gym. It can be, getting them into a work environment. So I think that you really want to think outside the box, because it really can be used for pretty much anything that has to do with development and behavior.
Okay, I think that's all. Oh, we have one in the audience. Yeah, do a double tap or something.
I just yell? Is it, okay. What would anxiety or depression look like in my 4-year-old? I mean, I get that it could be easy to spot in an older child, but
Yeah, it can be tricky. I think that it usually presents in kids who, in kids is irritability more than, oh, I'm scared, or I'm sad. Often it's, I'm just really irritable. I'm not, little things bug me, things that didn't bug me before. Also, one thing you can think about is separation anxiety. Like that's something that it doesn't necessarily mean you're going to have anxiety down the road, but if it's really significant, then that might be, a clue. I had one patient who we didn't really figure out, we thought he had ADHD. We didn't think about anxiety till he went to Party City at Halloween and he got really scared. And then there was a way to kind of talk about anxiety at that point and put words to it. And we actually realized that he had a lot of anxiety. So I think irritability, phobias, like they don't, the bugs, the weather, the dark, there can be all kinds of things. One patient didn't like going over bridges, so, I mean, it's so variable and it's hard in a 4-year-old. But I think it's always something you want to think about because I think it gets missed because your 4-year-old probably isn't going to tell you, I'm worried about school tomorrow, or that kind of thing. We did. Well, thank you, you guys. And as one of my med students said, after being in clinic with me for an afternoon, these people are heroes. So you're all heroes.